but we'll go ahead and jump in and get into this talk. I totally agree with what Tricia said. I think this is a critical topic and one that has been exciting for me to learn more and more about from research, but also from amazing institutional leaders like Sheryl. And excited to talk to you guys today. So the objectives overall, my goal is for all of us to walk away from today's talk with increased focus, awareness, excitement, and urgency surrounding trailblazing health equity efforts within our department. And the way that I hope that we'll build that attention and focus is through our objectives. So we'll talk about health equity kind of on the local level, boots on the ground when we think about quality improvement. And then over the course of this next hour, we'll scope both into the boots on the ground, but also to the large scale, what's happening across the organization and even nationally when it comes to thinking through health equity. And we'll rely on Sheryl and giving us the context for what is happening. And then we want to end by building a roadmap for what things could look like moving forward. So to set the stage, hopefully many of you have seen this before, but within quality and safety, we have a list of strategic priorities, both for safety and quality initiatives. And these are probably coming as no surprise to most of you that these are typically the things that we think about when we're talking about quality and safety: mortality, readmissions, length of stay. And we even had the opportunity to hear from Kristen Miller, who's here last week, about the great quality improvement work happening in the ICUs. One task that I was got the opportunity to partner on was about 8 months ago, joining with the interdisciplinary group across the organization to look at our care for patients with sepsis and improving our outcomes. So when embarking on any quality improvement project, we become familiar with looking at the data to help guide us in how we're going to think about where we need to target our improvement efforts. And this slide contains a couple terms that may be unfamiliar to some of you, but sepsis DRGs stands for diagnosis-related groups, and these are the catch-all primary category for a patient who comes in, primary reason being sepsis. Sepsis DRGs are our top diagnosis when it comes to mortality and our top diagnosis when it comes to readmissions, both index and return admissions. And the other term here is observed to expected mortality. So instead of looking at just at our overall numbers of events or patients that die, we look at our observed to our expected, which is based on the acuity and the comorbidities of a patient. That helps us understand how essentially good we're taking care of these patients. So you could imagine that a 30-year-old who comes in with no past medical history with sepsis from cholecystitis probably has a better prognosis than an 80-year-old with a renal transplant, diabetes, and cancer who comes in with sepsis. So the observed to expected allows us to in some ways control for the comorbidities of the patients that we're taking care of. So you see our observed to expected sepsis mortality is 0.94 over the last year, which is good in the sense that we have less patients who die than we would expect. And it puts us actually around the 70th percentile, which lower is better compared to other academic centers. And then you can see in terms of absolute numbers, sepsis blows really any diagnosis out of the water in terms of how many patients have die from sepsis. Now, this is all quite familiar and comfortable for me to look at when I'm thinking through any quality improvement project. But what is less familiar and less comfortable are looking at quality improvement and outcomes through different lenses. So recently, we've had the ability now to filter through diagnosis based on new patient characteristics, including race, ethnicity, their preferred language, and where they're coming from. So the hypothesis could be that maybe our patient outcomes from sepsis could be dictated by more than just their case mix index or their comorbidities. And so what we found may or may not be surprising to you, but if you live in a wealthier, on average, zip code, you tend to have a lower mortality observed to expected from sepsis. So you can see this is the zip codes overlaid of a partial map of Virginia, and we're located right in the middle here. What I did for this is I took the 3 zip codes with our highest observed to expected mortality, and I looked at the average income and compared that to the lower income. And what you can see here is that on average, the zip codes where we had higher mortality had a higher proportion of individuals making less than 50,000 and a lower proportion of individuals making more than 100,000. So difficult to know what to make of this, but we have this data now. And how about if we look at race? Well, if you are white, you may be surprised to see this, you tend to have a lower observed to expected mortality from sepsis. So I said a couple minutes ago that our observed to expected mortality was 0.9, but we see that that benefit, or that lower than 1, which is what we want, is really driven by observed to expected mortality among our white population, where it's 0.79, as compared to our Black race, where it's 1.01. So we have this new filters, this new way of looking at data, and the question is, what should we be doing, if anything, about this, especially when it comes to how we drive forward our quality improvement projects? Well, one way to think about it is this new and specific to VCU? Well, unfortunately, sepsis mortality disparities are not new. So this was a retrospective study from the year 2000, so a while ago at this point, that looked over 20 years using ICD-9 coding, and saw that though sepsis mortality fell over 20 years, the mortality was highest among Black men. Well, we know a lot has changed in the last 20 years. Is that persistent? There's an update study. This was published in Critical Care Medicine. We're cutting off the bottom of it, but we see that compared with whites, the sepsis-related mortality rates were higher in Blacks, Native Americans, and Hispanics. And this is in the past 20 years, from 2000 to 2019, I believe. And then we can take an even larger view out and look at the larger cultural events that have cast health equity back into the spotlight, as if it did not already need to be, based on that data that we've seen of things that we've known since the 1970s. This is not solely related to health disparities and health inequities, although that has been very well documented, including the article published in JAMA that looked at excess mortality among Black and other minority populations during the COVID pandemic, but also wider cultural issues such as the Black Lives Matter and the murder of George Floyd. This is something that people are talking about beyond just the healthcare world, and the call is existing now from everywhere that action needs to be taken. And these are just a few examples from leading organizations that are talking about how we need to make health equity a priority now. So putting it together, we have a quality improvement project here at VCU, improve our care for patients with sepsis. We also have historical, consistent, and relatively unexplained outcomes differences for some patient populations. And we have VCU data that appear to reflect these same trends. So not every difference in outcome is a health equity issue, but if the difference results from injustice or unfairness, then this is by definition inequity. So let's take a step back and just review, just to make sure we're all talking about the same terms. What is health equity? So this is the state in which everyone has a fair and just opportunity to attain their highest level of health. And there's a lot of different pictures and graphs that depict this. Frequently you see people trying to pick fruit on a tree. But I included this one. You can see the difference here between equality, where everyone has the same opportunity, but it is disproportionately benefiting some, this third person in this picture, versus equity, where everyone has a fair and just opportunity in the context of health to attain their highest level of health. And according to the CDC and other leading organizations, achieving this requires ongoing societal, and I would argue hospital as well, efforts to address historical and contemporary injustices, of which we know that Richmond has had many through our history, overcome economic, social, and other obstacles to health and healthcare, and then eliminate preventable health disparities. And you may ask, well, this sounds right aligned with quality improvement, and has this always been identified? And the answer is that really it has been. Pursuing health equity has long been recognized critically as an element of quality improvement. This picture is from the 1999 To Err is Human report, which many of you probably have heard of, that talked about and really cast a light on medical error and the adverse effects for patients that result. And in that, they helped to define what quality in healthcare should look like, because quality can be a tricky thing to define, and we're all experts in quality on some level. People are readily quick to criticize the quality of my baking or the quality of a movie that they watch. But when it comes to healthcare, the Institute of Medicine helped us define this using these 6 dimensions. And this acronym is STEEP care, that quality healthcare should be safe, timely, efficient, effective, equitable, and then patient-centered. And these really have not been controversial, but equitable healthcare has become known as the forgotten aim of healthcare quality, because while we've made substantial efforts and interventions regarding some of these other dimensions, the achievement of health equity has remained elusive. So much so that over the last years, there's been renewed effort to even highlight health equity further beyond just a dimension of quality care, but looking at it as a necessary to achieve quality care. So you may have heard of the triple aim from IHI. This is kind of a framework by which we think of any healthcare quality improvement project should be looking at. And historically, we've said we got to improve our patient outcomes, we have to lower our costs, and then we have to improve the patient experience. And all healthcare quality improvement projects need to be focused on fulfilling all three of those dimensions. And different dimensions now have been proposed, including now adding health equity. To the point of, this is a good commentary from JAMA that I enjoyed reading, and I'll just read the one quote: "There's no equity without quality, there's no quality without equity." And so to conclude this part, I'd say equitable care is really critical in defining quality improvement. And then without a specific focus on including equity in our quality improvement work, our risk is that we could worsen healthcare disparities, and these go hand in hand. So with that, I am going to turn it over to Sheryl to talk to us further about some of the ongoing work surrounding health equity at VCU.
Thank you so much, Dr. Biederman. Thank you for including me in this presentation. Very excited to talk to you today about some of the efforts that are underway here at VCU Health. So I want to start with reflecting on Dr. Biederman's quote or question about patient outcomes, and are they driven by more than case mix index? And there is a huge body of literature and many studies that say, yes, they are. And I'd like to start by referencing the County Health Rankings model that was developed by University of Wisconsin's Population Health Institute. This is a model that was developed about 10, 11 years ago, in which the County Health Rankings actually publishes a report every year for each state in the country and ranks the overall outcomes and the quality of care for every county and locality in the state. If you're interested, you can go to their website and download Virginia's, which is used by our leadership team to really help understand what are some of the critical issues that the populations that are being served are trying to deal with as they focus on being as healthy as they can be. This model basically says, if you look at the factors that influence health outcomes, which can be measured by how long people live and their overall quality of life, they can be broken down into 4 categories. First is health behaviors. These are personal choices. Do you smoke? Do you drink? Do you exercise? Represents about 30% of the factors. Access to healthcare actually only represents about 20%, or clinical care altogether. But then when you look at the social and the economic factors and the physical environment in which people live collectively, they can be called the social determinants of health. And they together represent about 50% of the factors that influence the overall health outcomes for individuals. And if you're interested in what are these social determinants of health, here's an infographic that was developed by the Kaiser Family Foundation a few years ago. But essentially, these are the conditions in the places where people live their lives, where they have their ongoing activities that really influence their overall health. And these factors really do have an influence on morbidity, mortality, life expectancy, and overall health outcomes. If you are interested in learning a little more or doing a deeper dive into this, I would ask you to spend some time looking at the VCU Office of Health Equity's website, which has some information that helps you to understand not only what we're doing here, but a little bit more about what's going on in our communities through our History and Health program that has a series around equitable access to care as well as racial equity. There's also a very interesting pilot that you might want to learn more about called Facilitating Patient-Centered Compassionate Care that was put together to help introduce our house staff to social determinants of health and how they impact the care that's provided in our organization. But I do want to spend a few minutes talking about what's been going on here at VCU Health in regards to addressing health equity. And I'll start with a federal initiative that our organization was involved in from 2017 to 2022. And it was a huge, huge research project launched by the Centers for Medicare and Medicaid Innovation that really wanted to test a model that looked at if you rolled out a systematized process of screening and referring Medicaid and Medicare beneficiaries, could you really impact cost, utilization, and the overall quality of care? And this is the model that was given to 28 communities across the country, with Central Virginia being one of them. While we still do not have the outcomes data from CMMI, which is being evaluated now from the 28 communities, what we do know is a little bit about what was going on in the lives of the individuals who were screened. In the Greater Richmond area, this initiative was coordinated by Health Quality Innovators, which is a quality improvement organization that supports federal initiatives. There were over 36,000 individuals identified, with close to 22,000 actually being screened. And what we found when we looked at the population is that there was a high prevalence of food insecurity, housing instability, and transportation needs amongst the population here in the Central Virginia area. This was very important because what we also gleaned from the population that was screened was about 50% of them had been to an emergency room at least one time within the 12 months in which they were screened, that 3 in 5 reported at least one of the health-related social needs that we were screening for, and that about a third of them really needed intensive navigation to get to the community resources to address the issues that were identified. We've learned from this information, and here in Virginia, there are a couple of really interesting things that are underway to help healthcare organizations connect with community-based organizations that can address these issues. The first is that the state used CARES Act money a couple of years ago to invest in the development of an electronic referral platform called Unite Us that has been launched in 5 regions across the Commonwealth. Here at VCU Health System, we have signed up over 200 users who are able to go into that tool. And when we identify individuals who have needs, we can connect them with community partners who can address those needs. We've also partnered with the YMCA that has developed a broader network that includes Unite Us, but it's called Help One RVA. It has an outward-looking initiative where community members can go in and look for resources, as well as the Unite Us platform that will allow healthcare providers and partners to go in and connect people using that Unite Virginia platform. While we've been able to plug into these initiatives across the state, what we've also done is a deeper dive into what's happening right here inside of our health system. And we started with a study that was supported by Dr. Rebecca Etz from the Department of Family Medicine and Population Health, where we asked the question, are those needs really prevalent, not only in the community, but in the population that we served? And so she did a very small study that looked at about 200 of our patients in our general internal medicine units and our EDs. And this is the data that we found. Again, highest prevalence for transportation, food insecurity, and housing instability. And we took that data and decided to do a deeper dive and launch a pilot. And our pilot was with our partner Feed More, Central Virginia's food bank. And we started with a pilot on the outpatient units. We looked at 4 of our primary care clinics, received some funding, not only through Feeding America, which is the national coalition that focuses on food insecurity, but they partnered with the National Anthem Foundation, and they wanted to know what happens if you have a food bank partnering with a safety net hospital to try and identify whether or not there are food issues, food insecurity issues in their outpatient clinics. We did screenings, and in the first year, we screened over 1,000 people and gave out over 440 food boxes for people who screened positive, but realized that it wasn't just about the food boxes, that we needed to make sure people had access on an ongoing basis. So connected them to the hunger hotline so they could connect with pantries in their communities and help individuals sign up for SNAP. But then we said, what would happen if we took this model to an inpatient unit? And so we partnered with folks on North 5, which when we started the project had a higher 30-day readmission rate than other general internal medicine units. And we decided we'd screen for those 3 health-related social needs where the prevalence was most high in our pilot population, and then asked our outreach worker who was doing those screenings to join the flash rounds, so that as our clinical teams were talking about discharge planning and treatment plans, they could also think about these health-related social needs that were having an impact. Very interesting results. We ran this pilot for about 14 months, screened over 700 or touched over 700 patients, and we had over 340 who had at least one need that was identified. And here's what we found. The orange line represents the 30-day readmission rate for the entire North 5 population over that 14-month period. The green line represents the 30-day readmission rate for those 347 patients who screened positive for at least one health-related social need. And what you can see is for the vast majority of the time, we were able to reduce the 30-day readmission rate. And for those months where it was higher, when we did a deeper dive, we realized it was only 1 or 2 patients that were driving the data. So we felt very confident that addressing health-related social needs could impact health outcomes. Well, while we were having fun trying to figure out were these the types of initiatives that could really support our population, along comes the Joint Commission and the Centers for Medicare and Medicaid Services, which have introduced new standards that are focused on addressing health disparities and addressing health equity. Joint Commission has said that this is so much of a priority that they've not only introduced new leadership standards that became effective January 1 of this year, they've determined that starting in July 1 of this year, that their health equity leadership standard will now become a new national patient safety goal. So what is it that CMS and Joint Commission have asked us to do? Just compiling the regulations and the standards from both of them, they're collectively called health equity metrics. The first is that hospitals need to have a strategic plan that helps guide their efforts around advancing health equity. Our board adopted a new strategic plan last May, and ingrained in that was a goal that's focused on addressing health equity. The second relates to our patients needing to be screened for these health-related social needs. We've already implemented the screenings at all 3 of our acute care facilities, at VCU Medical Center and our hospital-based primary care clinics, and from many of our high-risk inpatients. But by January 1 of 2024, all acute care hospitals across the country that participate in government-sponsored programs such as Medicare and Medicaid will be mandated to screen all adult inpatients for 5 health-related social needs, those same 5 health-related social needs that were a part of that CMMI Accountable Health Communities Initiative. Another key initiative is that we need to not only collect demographic and social determinants of health data for our patients, but it needs to be in our electronic medical record. Right now, we are developing a job aid that will be rolled out to individuals who are collecting race, ethnicity, and language information to make sure we're doing it accurately and putting it into our EMR to help us as we then look at identifying healthcare disparities in the populations that we're serving and developing the action plans similar to what Dr. Biederman talked about in the first part of his session. We're very excited about this. We've started with our HCAHPS data, identified some disparities in our acute care facilities with the goal that we'll be working with our performance improvement teams to launch action plans. And then finally, we need to make sure that all this work is shared with our key leaders, with providers, and with our boards so that we continue to move in this positive direction. And there's an intranet site that's actually been set up so that our team members can watch and gain information on an ongoing basis. We're also leveraging our EPIC tools. And one of the things that you will see over the next few months is the rollout of information of how it is that you as providers can see what's being documented in our Healthy Planet Social Determinants of Health wheel that is being populated by our care coordinators, our social workers, our discharge planners, outreach workers across the organization. To support all of this work, a community health partnership fund has been set up. We've been testing it for a couple of years, but now we're going to be very intentional with this fund. It was established so that we can make some targeted investments in how to meet unmet social and economic needs of our patient populations. The idea is to take the information that we're gathering from these screenings that we'll be conducting going forward, identify the community partners and agencies that can help us to address those issues, and then invest in those organizations so that we can expand their capacity. So when we make the referrals, our patients can get connected. And then finally, I want to give a shout out to our quality and our safety data analytics team that has put together KPI dashboards that provide a view so that we can look at our clinical data through a health equity lens. And as Dr. Biederman showed in the very first part of his presentation, this is powerful data that now lets us look at our clinical outcomes with a new view and begin to stratify what's going on with our populations and do deeper dives that allow us to develop these action plans that are very focused and targeted to help improve the overall outcomes. And so if you're interested in taking a look at those tables, please contact our quality and our safety data analytics team so that you can learn how to get access to our Tableau tables. And with that, I'll turn it back over to Dr. Biederman.
Thanks, Sheryl. Really exciting stuff. And it's always great to hear, even if we ran through this yesterday and I learned more again, even hearing from you again. So thank you very much for sharing. Question, is it realistic to champion health equity in our daily practice? So wanted to give you 3 concrete examples, and these aren't like mind-blowing, overwhelming projects, and frankly, maybe weren't thought about with the lens of health equity, but I just wanted to give you some examples. One, so equity at work. This is Dr. Chopsky, who's a hospitalist and the medical director at CSBC, and Jackie Bishop, nurse clinician down there, improving the process for communication to families of admitted incarcerated patients. The problem is that incarcerated patients who are admitted to the hospital, we have security concerns, right? And it's not appropriate to share location, discharge times, where they are in the hospital. And frankly, this has resulted in confusion as to when staff could contact or update family members, and therefore decreased the amount of contact that families of admitted incarcerated patients have received, even under conditions or circumstances where really the right thing is to contact the family members. And so the equity concern is that decisions regarding medical care are importantly made in conversation with family, and the lack of procedural clarity that we had here at VCU led to decreased involvement in necessary situations and important patient conversations, including those where patients had experienced ultimately negative outcomes. So the improvement, simple, but updated policy created in collaboration from nursing, physician, and security, which within I didn't finish that slide, so I apologize. It outlines clear process of communications and how the process should happen, so that when you have the question, it's easy to see how and when it's appropriate to contact family members. Second example, addressing transportation as a social determinant of health in cancer patients, coming out of Massey, which has really been a leader for years in this space of looking at communities and how we partner with communities. So the problem, transportation challenges limit some patients from making it to clinic appointments, as Sheryl had mentioned, as one of the leading social determinants of health. And the improvement is having medical outreach workers assisting patients with transportation challenges in connecting them to resources. And the anecdote that they gave is about a patient who was unable to navigate the system to find the actual benefits that she already had. So it wasn't even giving her a new benefit, it was helping her to understand and navigate the complex care environment and supportive care environment that we know is out there, and is such a challenge for our patients to navigate. Our third final example also comes from hospital medicine. One of our APPs, Amber Balzer, who's now the Quality and Safety Director for Hospital Medicine, did a project noting that a problem of healthcare workers writing discharge instructions and sometimes using medical jargon or writing at a literacy level consistent to their level of education. Well, the equity concern is that limited literacy by some of our patients means that important instructions could not be understood. So what was the improvement? Reformatting discharge instructions to put the most important and relevant information at the top, and then concerted educational efforts to use patient-friendly language at a more appropriate reading level. So just a few small examples of how quality improvement efforts within our department have been making small changes to improve the outcomes for our patients. So the last objective, which we'll go through, is what now? What should we be doing? Because sometimes it can feel, to me at least, is that we're being asked to do everything, everywhere, all at once, which was my favorite movie of last year. And I encourage everyone to watch it. But we know we have the tripartite mission of the Department of Internal Medicine: care, teaching, and research. And then we are often hearing about quality improvement, and now you're asking me to focus on health equity. Seems overwhelming to think about all of these as discrete items. And what I would propose is that instead of thinking about them as discrete items, that we think about both quality and safety, or we think about health equity similarly to how we think about quality and safety as underpinning and the foundation for all of the work that we do, whether it's in clinical care, education, and research. And so it's a necessary foundation upon which we build into the efforts that we're doing in our day in, day out work. So what are some immediate things that everyone here could do to advance health equity? So the first category is learning. You can start by familiarizing yourself with VCU's 2028 strategic goal to advance health equity, which Sheryl referenced, but Quest 2028, one of the key priorities is identifying and eliminating health disparities. You could consider the equity action plans within your subspecialty organization or through leading organizations such as IHI. So whether you're a cardiologist or oncologist, look at your leading subspecialty organization and how they have committed as an organization to health equity, and let that be brainstorming for how we could bring some of their ideas and interventions here to VCU. You can learn by attending university education talks, like Sheryl also mentioned, through the Office of Health Equity or the Diversity, Equity, and Inclusion Office, to learn about the history and what's of Richmond and how some of these health disparities have been long ingrained in the history of our city. And then, for those who are even more interested in growing this as an expertise, Marcelle Davis recommended taking DEI courses. She recommended a really good one from USF, and I'll put the links in Quality and Safety newsletter, which is coming out next week. So you guys can access this, don't need to remember that offhand. So we can learn more, but we should not stop with learning. We can commit to health equity as a core component of our tripartite mission within the Department of Internal Medicine, which is why I'm really thrilled to hear Tricia talking about that at the forefront as a priority from her perspective as well. You can participate in surveys to assess the departmental's needs and understanding of our current state. And then, as Sheryl mentioned, requesting access and taking a look at those dashboards, which anyone can have access to look at our mortality, readmissions, and length of stay through many different lenses, including health equity lenses. The next category is to act. We can bring up social determinants of health in our daily rounds when we're talking to our patients, but also when we're talking to our learners, the next generation of physicians, and building that into how we're having our conversations around our care plans and how we're taking care of our patients. And then using that, even though we often do not have the power in and of ourselves to connect someone to resources, to put them in touch with the correct with the appropriate folks like our care coordinators, social workers. And then finally, this, as you've heard from Sheryl, this is such a massive effort from national level to the organizational level. And the biggest part of this in having conversations with many different disciplines is that this is a team effort. There isn't one group or department that is capable of achieving all of this on their own. And if we don't have every piece of the puzzle, then our impact to our patients is going to be incomplete. And so a huge and crucial part of this puzzle piece are us, the clinicians that are taking care of these patients, that know their health needs, that know what's going on medically, and how can we connect them to the different groups that are able to connect them to resources and help address some of these health inequities. So what I would love to see happen within our department is to establish a group of folks who are interested in this across the department in our many different specialties, recognizing that the needs of and the ideas of different folks are going to be quite different depending on where you're coming from, but thinking that the diversity of ideas and inputs would really be a benefit to thinking through how we can better serve our patients. And there's a lot of there aren't a lot. There are several frameworks for how to think about this if you are embarking on a group to look at health disparity, health equity on a departmental level, which might start by looking at and understanding what the current state is. What are the needs of our patients? And then what are the needs of the faculty and staff within our department? And then to what I said before, we're not alone in this effort. In fact, there are so many departments and groups across the organization that are excited and willing and eager to partner with us. We have the patients. We're the ones who know and take care of these patients, and but we don't have the expertise. Fortunately, we've got folks like Sheryl and Marcel and others who are able to help and partner with us in putting all of these pieces together to address health equity. So what would this look like? What my hope is that we build multidisciplinary Department of Internal Medicine team. We understand the needs of the patients and the communities that they live in. And again, this is not something that we, in and of ourselves, need to have all the answers, but we have the expertise and the input from leaders throughout the organization to help guide us. And then we discover the needs of our staff, residents, and providers. Equal parts in this roadmap to addressing health equity. And then we connect with the health system resources. So with that, it's been a privilege and pleasure to talk to you all about the challenge of health equity, the forgotten aim. I hope you felt motivated and jogged or brainstormed how you can think through in your daily practice addressing health equity. And I'll just leave you with, hopefully we are all thinking through health equity as a foundational part of how we take care of our patients and not separate than the care that we provide or the education that we give or the research that we conduct. So with that in mind, thank you so much for joining. Like I said, I'll send the references and resources within the newsletter coming out next week. And if you have questions, ideas, or ways that you think you would like to get involved, please email myself, email Sheryl, and special thanks to Sheryl, Marcel, and Tara for putting together some of this data. So with that, we'll take any questions.
You have microphone for questions?
So great presentations. Great presentations. And I was actually listening to your presentation in my office, and it was so interesting that I just ran here to be in person. Okay, so I have two comments. First comment on the septic patients. It is interesting but not surprising that there is a relationship between, or an association between mortality within septic patients and race. The question for you, and maybe the next step, if you don't have the answer, is what is the acuity of illness of those patients at the time of admission or at the time they step into our emergency room? Because it may be that Black patients have worse or greater acuity of illness at presentation than other races. And that may be driving the. And the reason why I'm bringing this up, Dr. Biederman, is because, as you know, we're getting ready to implement intervention. And
for comorbidities, but what was not controlled with the acuity with which they present. Standard. But that doesn't get at the underlying cause there. And frankly, with this disparity, and there could be 1,000 explanations for why. And the critical care medicine article offered a couple hypotheses. What I think we need to do is take that deeper dive, take a look and see, and maybe could be part of causing this. But it's certainly something that until we start having a conversation, it's not even.
second comment, I don't think.
I think.
So the second comment has to do with the way that this improvement across prioritized MSDRGs. And I am hoping that health equity at the health equity lens will be part of clinical processes and order sets, which are probably especially relevant for the time of discharge interventions, right? There's little that we can do in the inpatient setting, right? But maybe we can, as you showed, Sheryl, better guide what happens in that at the discharge, at the point of discharge.
Thank you for sharing that observation. I completely agree. And one of the things that I've learned in working with clinical partners over the years is that, number one, we need to find out what the issues are early in the care process rather than at discharge. There have been specific instances where the discharge has actually been delayed and we've extended the length of stay because as the discharge planning was happening, we found out that a person was homeless or that they were having difficulties with their utilities and they were being discharged with medications that had to be refrigerated. And so these types of issues do need to be identified on the front end. But the other piece is that there's a host of research and literature that says we've got to think about the whole person, their family structure, their social structure, if we really want people to achieve the outcomes that we have outlined for them. And so if we're not taking those things into consideration, it's very difficult to have the best clinical outcomes. And so being mindful, even if it means trying to figure out how to partner better with other organizations and our own internal resources that can help us to brainstorm about how to solve the problems, is going to be critical for us to achieve our goals.
One more thing. I wonder if we can align in those MSDRGs that should be prioritized, because just like in quality and safety, I can think of thousands of quality and safety projects in many different areas, but hopefully we can align on the ones that are priority for the system, which are based on, number one, volume of discharges, and number two, on costs / charges, and the dispersion of the variability. So the variability of the costs, so that we have a guide on which have priority. My concern is, great, people want to work on health equity, but if you don't prioritize efforts, you have 1,000 different people doing 1,000 different things and you achieve nothing.
And I agree. And we can also go upstream and think about how we can work with our public health partners differently, because there's so much data that's already been published that helps us to understand which communities, which census tracts are tracking for very high rates of chronic conditions that ultimately, if they're not managed appropriately, end up with acute care episodes. So there's lots of work. I loved your comment earlier about going upstream and looking at what's going on outside of the hospital. Thank you.
So a very quick comment and then 2 questions. So we have a paper that's about to be published, which we surveyed providers in this institution about the impact of race on healthcare associated infections. Most people didn't know that there was an impact or didn't believe it, which is a bit disheartening. So I think there's a lot of education to be done on multiple levels on equity and outcomes. That was just an example. First question is, the North 5 pilot I thought was amazing. I'm assuming that's unique. If you haven't published that, you should. And the question is it still ongoing? And if not, why?
It is not ongoing. We had to stop it because truly COVID. If you recall, I'm preaching to the choir here. Our priorities shifted a little bit and we had to pull our outreach worker, and we actually engaged students off the unit.
Is that coming back then?
Well, that's a good question. We need to think about that. I will put it this way. The screenings are being done in a different way. So now the care coordination team is looking at how their clinical team members can engage in the screenings for the health-related social needs as a part of the ongoing process to prepare for discharge. And so it's coming back, but in a different way. And then remember, CMS has already told us we have to do screenings for 5 health-related social needs. So one of the activities that's happening now across our entire clinical enterprise is to figure out how to get those screenings done for all of our adult inpatients and document the findings in the EMR. And then how do we connect the patients in need to community resources?
Okay. I mean, I get that. I think that Sylvia would probably agree with me. Publishing things like that institutionalizes change big time. And some of the people that were involved in that may no longer be here. So you need those kind of publications to urge or promote action. And the last question I have is, how would you, with all the initiatives that you have ongoing, maybe the call to action that you had there, Steve, what are the 3 ways that you would measure the success of your program here?
That's a really good question. How are we going to measure the success of our equity initiatives? Is that what you're saying? Or
Exactly. How are we going to measure the sustainability and success?
Yeah, and that comes to any quality improvement project. We have to, I mean, in fact, when I'm thinking about health equity, as I'm talking about, thinking at it through the same lens that we think about quality improvement. So asking the questions like, what are we trying to solve? How will we know that are changes in improvement? And then how are we going to measure it? And so, I mean, if we're talking about the general concept of health equity, it's difficult to just say like our health equity levels are increased here at VCU. And so I think then what that means is that when we're looking at any project that we're doing, being concrete and specific and using that data and those outcomes that we're looking at in that project with the lens of health equity. So for the sake of sepsis, for example, we have this data in front of us now. We are looking at, although our numbers are limited, we can see our outcome numbers for different races. Well, we shouldn't expect those disparities to persist or without investigating why that's happening and looking into what are the drivers for that. And it's difficult for any project to look at like the long-term outcome measures. Those are oftentimes distant and far in the future, which is why we often use process measures. And so a great example is the screening for the social determinants of health. So if we find that there is part of our process that's broken or is not advantaging or disadvantaging some of our patients, how can we fix that process and use that as a measurement, if that makes sense?
Oh, yeah. I know something about process and outcomes.
And I will just add, we do have process metrics for the health equity initiatives, but I think it's also important for us to all remember that health disparities are a metric in regards to whether or not you are achieving health equity. And so as long as we are seeing disparities and we're willing to do the deeper dives to understand who are the populations, what are the drivers of the outcomes that we're seeing, and we're willing to dive in and address the issues, not just the clinical issues, but the other factors shown in that county health rankings model that are driving those outcomes, then we have a chance of closing the health disparities gaps and really working towards achieving health equity.
It would be great to understand as the science of this evolves, what's the anticipated or expected impact of your outcomes on your measurements like disparities. The one thing I know very little about is in healthcare associated infections. And we now know, and Sylvia would agree with me, I think, is that with the best infection prevention science can probably only impact about 70% of infections. So having that kind of estimate and understanding of like, we do this and we get that, I think is really important in communicating your programs, your outcomes, and really recruiting people.
Yeah, I would agree. Oh, go ahead, Dr. Dow.
A question, and feel free to turn this back on Dr. Biederman and Dr. Munoz-Price. The sepsis prediction tools that we have, the one in Epic and what we've been using before and other things, imperfect. We know there's a lot of false positives on those and then some false negatives where you miss certain populations. Do we know if there are inequities buried under that? And does that help us start to think about whether that's a manifestation of preceding inequities before people come into the hospital or systemic bias and other things that may be happening in the processes of care in the hospital? And that's probably a whole talk into itself, but that's what I'm gonna let you ask that if they have comment.
Yeah, that's an important question because it goes back to the data that we use to drive our change and how accurate that is and how relevant it is. I can tell you for the Vizient data, the observed to expected, race is not a part of that, but they are starting to use for observed to expected mortality through Vizient, some social determinants of health. For example, homelessness as a status, which would increase your expected mortality, which is aligned with what we've been talking about today, that when you have social determinants of health present, then we can expect that you're going to have higher rates of adverse outcomes until we address those. When it comes to the predictive algorithms of many different scoring systems, I think I would probably defer that to a lot more investigation needed, or we could hear from our senior leadership in quality and safety.
So let me tell you that Epic has proprietary algorithms for their scoring system. And by the way, it is a very inaccurate scoring system that they have. In the future, what we're building right now at VCU Health System is an EDW in the cloud that will allow us to combine variables, hundreds or thousands of variables on our patients, many of them real time, so that we can use machine learning to tell our system, this patient had sepsis, this patient had sepsis, this patient had on and on until, and then that's phase one. Phase two will be trialing that to see how well that matches what we're seeing. And phase three will be to have the system tell us this patient is going to have the bad outcome once it is validated. So we're moving towards that. It may have raised as part of the predictive model.
I think what Sylvia is referring to is precision medicine. And that's a growing field in quality safety and infection control, using algorithms and artificial intelligence to be more predictive instead of using blanket algorithms like we're doing with the sepsis bundle, which I think JAMA wrote a paper. There was a paper published in JAMA on the sepsis bundle from Epic, correct? Was it? Which was terrible. I mean, it said it pretty much was horrific.
Yeah. For the purposes of this talk, that's not really what I would want to dive into, although yes, there's a lot in that paper that discuss limitations for Epic's sepsis predictive model. And I'm all for using big data to help guide our change. At the same time, we definitely need to remember the patients in front of us. And in many ways, like when we have a nurse or a physician in front of a patient and assessing them, like how do we equip them to do the best care that they can for those patients? And so all for using big data, and I think that will help be a tool that we use, but not a substitute for the work that we need to do among ourselves.
So, as you're talking about precision medicine, I think you need health equity measures as part of that precision medicine. It's not how we typically articulate precision medicine, but I think it's very clear that that needs to be thought of in that kind of context.
Time is up, but I want to thank our speakers. Thank you so much for coming today.
Write that
Thank you all
paper.
so much.
Dr. Biederman, write the paper.